Hello, thank you for joining us today. We'll get started in just a few minutes. Hello, thank you for joining us today. We'll get started in just a few minutes. Hello, before we get started, feel free to use the webinar chat to say good morning, good afternoon, or good evening and tell us where you're from. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speaker and planning committee members have disclosed no relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into the learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. This webinar is proudly sponsored by Colgate-Palmolive. We'd like to thank our speaker today for sharing their expertise with us today. Our speaker is Dr. Audrey Miller. Dr. Miller currently holds a faculty appointment at Florida International University, Nicole Wertheim College of Nursing and Health Sciences as a clinical associate professor for the nursing department and is the nurse educator program lead. Her program of research is in the field of oral health and preventative healthcare for underprivileged, underserved children. She developed an oral health educational program researching post-knowledge in Head Start families. Dr. Miller is not only a certified pediatric nurse, but a board-certified primary care pediatric nurse practitioner and holds a part-time appointment as a pediatric nurse practitioner with the University of Miami Health Systems Division of Pediatric Gastroenterology, Hepatology, and Nutrition. We are so thankful to have you and welcome. We'll turn it over to you, Dr. Miller.
Good morning, everyone. Good afternoon or good evening. Thank you so much for the introduction. It is a pleasure to be here with you all today. I'm excited, and I hope you get as much information from this session as I prepared. All right, so I have no conflict of interest at this point, no financial or no endorsement of agencies or companies. My description is to educate nurses at whatever level you are in the nursing profession on preventive oral health care behaviors that contribute to reducing the incidence of oral disease as a causal factor for systemic infections, inflammatory injury, and end organ damage. By the end of the session, a few of my objectives: identify good versus bad oral health, define what preventive oral health practices are, recognize the signs and symptoms of oral disease and disparities, and the causal effect of systemic infections and diseases like diabetes. I thought it would be a little cute to name my project Trick or Treat, since it was developed in October around the Halloween time. So we have to be very careful about that. So I want to give a little background about myself and how I came to be involved in oral health care and preventative measures for children. So back in, I think it was about 2005, I was a quality assurance nurse for Head Start. Hopefully many of you know it's a federally funded social program in Miami-Dade County, because I'm in South Florida. It used to be called the Community Action Agency. It was an umbrella for all services for children and their families. In about 2011, our then mayor, Carlos Jimenez, declared that there needed to be a merger. We had too many agencies doing basically the same thing, so it merged, and now it's called the Community Action and Human Services. So I wanted to give you a little background on that. Head Start is a federally funded social program. Head Start takes children between 3 and 5 years old, early Head Start from birth to 3 years old. So I was a Head Start nurse, so my population, of which I still love, is from the ages of 3 to 5. Some of the services included health. We had a division for health, nutrition, disability, mental health, and social family services. Because again, not only the children got the services, but the families did as well. So my focus was on health. And what we were required to do is the health screening for each child enrolled in a Head Start center. Miami-Dade County and Broward County, we have a county line there. We started from there until almost the tip of South Florida, Florida City. We went as wide east as west from Sweetwater, which is just before Okeechobee, Everglades, if you're familiar with South Florida, to the beaches, to the coastal line. At that time, there were 10 registered nurses, and we were called quality assurance nurses. Now that they've revamped everything, they're called health clerks. We were responsible for physical examinations, immunizations, PPD, their lab work, and lab included hemoglobin, hematocrit, red cells, and lead screening. And of course, the dental exam. Dental exam requirement was a yearly exam with prophylactic treatment for children and restorative care if needed. But there were several barriers to dental, and that's how I got involved with another colleague of mine back then. Some of the barriers included no insurance, low insurance, Medicaid providers not being available, no out-of-pocket financial support for the families, long time between their first visit and follow-up visit in excess of 4 months. transportation issues, the list can go on. We haven't even touched the disparities yet. So I got very intrigued as to why families would not take their children to get their oral health checkup once a year, which Medicaid pays for every 6 months here in South Florida. So I was on this journey to figure out what was going on. So the purpose of the investigation at that time was to examine the effects of an oral health educational intervention. I wanted to teach the families. I can't teach the 2- and 3-year-olds why they're not getting their dental, but I can absolutely teach the caregivers. And caregivers includes not your traditional mom and dad, but definitely your grandparents, aunts, uncles, foster parents, medical homes, etc. So I needed to do an intervention, knowledge and behavior specific cognitions and effect in caregivers of children between the ages of 2 and 5. Dr. Pender, I thank her because she was very gracious enough to allow me to use her health promotion model. Her model is very extensive, but she allowed me and gave me permission to modify it so to address the needs of my particular research. So the health promotion model is a theoretical perspective of factors and relationships contributing to health promoting behaviors, a guide of exploration of this complex psychological mind and body process that motivate individuals to engage in health behaviors, and an attempt to depict that multidimensional nature of a person's interaction with their interpersonal and physical environment. How can I do it myself? So this is my version of Dr. Pender's model, which she allowed me to address. So all I wanted to know was the individual characteristics, the behavior-specific cognitions, and the behavioral outcome, because my goal was oral health promoting behaviors at the end of my intervention and the family's intent to continue that educational process. So what did I find? There was a significant relationship between prior behavior and the behavior-specific cognitions. No significant relationship between the variables of age and income to the behavior-specific cognition. So whether or not you had money had nothing to do with why you did not find it self-efficacy or efficacious to indulge in oral health behaviors. Significant relationship between the scores of caregivers' knowledge and the intervention and their prior related behaviors. Significant relationship between the post-intervention scores, so scores after the intervention, and caregivers' intent to provide oral health care, and a significantly higher post-test for knowledge than they did for the pre-test. So what does that mean for us as nurses? Effective oral health educational interventions are absolutely needed, required. We do it every day in our professional lives. And so we teach and we reteach and we reteach and we evaluate thereon. Increasing health promotion behaviors and intent in caregivers. So I teach you, but I want to make sure that you're going to do the intervention that we want to teach. And increasing the caregiver knowledge or health promoting behaviors for themselves and for their children. So following the educational intervention and going through those health promoting behaviors. And then of course, decreasing oral disease. I always say if children watch their caregivers, they will mimic what their caregivers do. So if you are brushing and flossing, the child will brush and floss as well. Healthy People 2020 at that time, decreasing disparities in low-income children and their families, increasing access to oral health services, increasing pediatric dental providers, and decreasing oral disease. That is what Healthy People 2020's goals were, as oral health is an indicator, one of 23, of health disparities. So what's the problem? Children in America, less than 5-year-old, are either not getting preventive oral health care and or treatment, or they have already got dental oral disease. Children are 5 times more common to have dental caries or cavities than asthma and 7 times more common than hay fever. Infants from low families, low socioeconomic status, mothers that have low educational levels, and those who consume sugary foods are most affected. Children are 32 times more likely to have cavities by the age of 3 than those who do not have the above listed risk factors. So imagine if we could get the preventive oral health care in place, would minimize those risk factors that the children face. Oral health care is the primary preventive method of tooth decay and infection in children below the age of 5. Nonetheless, we're still having multiple infectious tooth decay, unnecessary sedative extractions, tooth loss and pain, nutritional concerns, and speech delays. I found it very interesting at Head Start that more than half, and I am guesstimating, of our children were in speech pathology, not because of cognitive issues, but because of missing teeth. You can't speak or enunciate if you don't have those front teeth, and a lot of our children did not at that time. Compounding the problem to this particular population of children, emotional problems, poor appearance, and low self-esteem. Now, I love my kids, but sometimes children can be cruel. And if your appearance is not 100%, they will bully and, talk about children who have missing teeth or who have the dark, etchings on their teeth. So what do? Many children less than 5-year-old don't receive routine preventive oral health care and possess oral health and are a higher incidence for systemic disease. More than half of children ages 6 to 8 have at least one cavity in their primary, and more than half of adolescents have at least one cavity in their permanent teeth. Baby boomers, and if you're a baby boomer, 1946 to 1964, this is the first generation that most people will keep their natural teeth over their lifespan. Why? We started fluoridating the waters. We started putting fluoride in toothpaste. Now, there are some controversial issues about fluoride in our waters and or toothpaste. I'm not here to discuss that today, but everything in moderation, it has significantly reduced caries in both children and adults. Problems with adults: risk to tooth loss, cavities, gum disease, poor or no salivation production, receding gum lines, softer root surfaces, and difficulty brushing or flossing due to vision, physical limitations, cognition, and or chronic disease. So they have some of the issues as well as our children do. A lot of the medications cause dry mouth, a lot of their health concerns cause dry mouth, and a harboring of infectious molecules in the mouth. So there are risk factors for the adults as well. Access to oral health care, low or no dental insurance. They might have medical insurance, but some of those policies don't have provision for dental. 3 out of 4 Hispanics and non-Hispanic Blacks have unmet dental needs. For every adult over 19 years old without medical, there are 3 with no dental coverage. That's significant. For our older adults, similar issues: have no or low income, lack of insurance coverage because of retirement. And some of those retirement funds, they don't meet the needs, their life, everyday needs. And so dental is on the bottom of the list. Racial or ethnic minorities tend to be on the lower part of the spectrum as far as care, access, and financial coverage. Older Americans with the poorest oral health, yes, due to illnesses, chronic disease. Smokers, long-term smokers, they're homebound and cannot get to a provider, or they're institutionalized and there are no provisions there at the institution for oral health care. So what are some of the disparities? I briefly spoke about the 2020 healthy people. So in 2020, in 2030, Oral health is still listed as one of the 23 health indicators and social determinants of health in the US. And that is because it is not a primary health need in some families. We're talking about food and light and rent. And unfortunately, with COVID, dental was, I don't even know if it was on the list or not, ladies and gentlemen. So access to care. Cannot afford out-of-pocket expense to pay for dental care, no public or private dental insurance, can't get the time off of work, and no or poor transportation. Medicaid recipients finding it difficult to locate dentists who accept their insurance, limited amount of Medicaid providers, limited amount of appointments for Medicaid patients, and poor or low Medicaid reimbursement for those providers. So Medicaid providers, not just for children, but in general, the list is very short. And multiple reasons, financial reimbursement is very low and not cost effective for some of the offices. Productivity. 35 million school hours are lost due to some kind of oral health emergency. $45 million are lost in productivity. If you're not at school, you're not at work, the companies are losing money. 20% of employed and 30% of unemployed stated low self-esteem due to their appearance. It's, the first thing we see sometimes is someone smile when we walk up. The ladies would say your hair, to make sure your hair is coiffed. But if you're not smiling, if you are not happy with your appearance as far as that is concerned, you won't go for that job, you won't go for that promotion, you won't do that presentation. So you end up limiting yourself because of the appearance. All right, disparities in children. Mexican American and non-Hispanic Blacks combined have 60% higher incidence for cavity in their primary dentition than their counterparts. They also have a combined 70% higher incidence for cavity in the permanent dentition than 54% of non-Hispanic whites. Which brings me to Diamante Driver. I'm not sure if everyone is familiar with him. This is a 12-year-old African-American, non-Hispanic male living in the Prince George County area of Maryland in the US. He had a tooth cavity. It turned into an abscess. And it wasn't until he was starting to feel pain, as reported, that the family knew that he needs to get the cavity fixed. At that time, mom did not or could not locate an available Medicaid provider, to the point where she lost coverage of the Medicaid. So now there was no insurance in the home. This is a low socioeconomic family. And he had a sibling that had severe early childhood caries, or ECC, and had 5 to 6 caries that needed to be treated as well. So the focus was on the sibling. However, by the time they realized how severe his abscess in the tooth and gum were, he was hospitalized for 6 weeks, some type of meningeal infection. He had 2 cranial surgeries, and they spent about $250,000 in hospital costs versus the $80 it would have cost to extract that tooth. Unfortunately, Diamante Driver died of infectious complications in February 2007 of the most preventable disease in children, an oral cavity. So I bring this story up, and we're all on the internet and Google and what have you. You can look this information up and the story. It's an absolute shame that in 2007, we haven't really come that far as access to care for minority groups. And as far as Medicaid, providers being available, appointments being available, or reimbursement. So I'm trying not to be on the political or financial aspect, but I think it would have been more cost-effective and life-saving had he been able to have that tooth extracted. Food for thought. Health disparities in adults. Twice as many Mexican-American and non-Hispanic Blacks combined have a higher incidence of untreated cavities than non-Hispanic whites. For the older adults, 90% of older adults have cavities or have had cavities. 1 in 6 have untreated cavities, and 20% have lost their teeth. So while the baby boomers are the first generation or to keep their natural teeth, we still have some tooth loss as we go on because of the aging process, bone demineralization, weakened gums, medication that we're on, chronic diseases, etc., contributes to the natural progression of losing teeth, but not because we can't get to the dentist or because we can't get oral health care. So oral health care includes preventing early childhood cavities, wiping gums and tongue of newborns after each feeding, brushing after each meal or at least twice daily, flossing twice daily, starting when 2 teeth touch. I had the pleasure of working with a pediodontist that the moment, and he worked with a pediatrician. The pediatrician would send him to that provider once 2 teeth touch, and that provider, pediodontist, would start teaching the families how to floss when 2 teeth started touching. Again, children mimic what you do. If you are brushing and flossing, I promise you, your little one is going to follow you and brush and floss as well. Open mouth examinations for children under the age of 1. I need to bring my nurses into the picture now, because at every level, I happen to be talking with a nurse earlier before the session, and she's absolutely right. Every layer of nursing, it doesn't matter what level you are in nursing, it's a responsibility to check our mouths, right? It's the gateway to our overall health and our growth and development, especially in children. We are what we eat. We put things in our mouth and it affects our oral cavity as well as our GI tract, as well as, our systematic functions. So each nurse at whatever the level they are can do an oral screening and assessment. Do a basic, any thrush or white patches in the mouth, how many teeth do they have, or missing teeth is easier to count, any cavities or dark etchings on the teeth, misalignment or crooked or malocclusive, those things can work wonders, and then refer. There are a lot of dental providers. We're working on the Medicaid providers, but there are dental schools and clinics, state organizations that will work with families of low socioeconomic statuses and give them based on what they make or not. So services are out there, and at each level, as we get to being a nurse practitioner, open mouth examinations, we can do that. We do that, right? So there is training for, and that is something that we're definitely working on. But you can definitely screen, especially for those that are in the hospital, especially those are in the ICU, to make sure that oral care is being done. And I'll tell you why, the connection. Dental examinations, including cleaning, fluoride treatments, sealants for those children who have permanent molars, and x-rays to make sure that there are no creeping cavities coming through either at the gum line or at the pits of the tooth. Preventing early childhood caries, as I said before. Increasing nutritional food intake, fruits, veggies, water, foods high in calcium. Controlling snacking on sugary, sticky, extremely hard foods, and foods high in acid, because it's that acid that stays in the mouth and breaks that tooth enamel down. And of course, abstaining from smoking or chewing tobacco, because that can contribute to oral cancers. Okay, so what is early childhood cavities? Severe enamel destruction, dental malocclusion, malalignment, pain, and our children are very adaptive and they won't say they're in pain. Sometimes they deal with it, they adjust and accommodate. And it's not until the nth moment that you realize there's no eating, there's no drinking, barely talking, no focus, lost school time, that something is wrong. Inflammation to the gums and abscess that could be potentially fatal, as I talked about, Diamante. So oral infection and diseases, most common, gingivitis. So poor or no oral healthcare practices cause an increase in plaque that adheres to the tooth and the tooth surface. Cavities or early childhood cavities, that demineralization of the tooth enamel by overgrowth and acid created by bacterial communities, or plaque, that sticky stuff that adheres to the tooth surface. Those culprits include Streptococcus mutans, sanguis, and there are other lactobacilli specific to the microbiomes in the mouth. Periodontal disease as we get older, result of persistent plaque covering the surrounding tooth enamel, inflammatory process and response to in the gums, and the gum starts to detach from the tooth and create pockets in that gum line, and then the tooth start to loosen, and that's how we lose our teeth. Or you get lots of spaces between the teeth, or you get those pockets. If you've ever been to the dentist and they put that little silver hook between the teeth and in the gum, they're checking for pockets or abscesses or inflammation in your gum. And of course, which leads to abscess because the micro organisms are just settling right in that nice space that has developed. It's nice and warm, it's dark, and it gives them, you're feeding them as we eat and drink so that it just builds in the gums. And of course, our oral cancers, not just smoking and tobacco, but HPV as well. So oral cavity is the gateway to the general and overall health and development of our bodies. Infection in that oral cavity can create a center of infectious activity that may develop into bacteremia, systemic infections, and inflammation. And those inflammations can cause end organ destruction and disease. Circulation of the bacterial pathogens from the oral cavity triggers that inflammatory response. Your CRP goes up, your tumor necrosing factor levels go up, interleukins and cytokines go up, your WBC goes up, platelet aggregation goes up because you have an inflammatory process. And so, your body's like, okay, I need to repair, I need to bring blood to the area, I need to stop the bleeding, etc. And of course, when your body's in a heightened state of infectious process, your glucose levels go up. So periodontal disease increases the incidence of bacterial pathogens that infect the tissue, bloodstream, and can colonize in distant organs. Cardiovascular system, bacterial endocarditis. There is a direct correlation to oral disease and bacterial endocarditis. Those microorganisms that go through the tooth, go through the tissues, go through the bloodstream, and from head down, it's going to circulate into the heart. All we need is one little bacterial pathogen to sit in the leaflet of our valves. Vegetation sets in, and before you know it, we have bacterial endocarditis and is on long-term antibiotic treatment. In the pulmonary system, bacterial pneumonia. We talk about those patients that are immobilized or hospitalized or chronic issues and conditions. And there can be some, minute aspiration going on, settles in the lung, and before you know it, we have bacterial pneumonia. So when we talk about nurses and their role is at every level and at every age span and generation. So we're cleaning, we have the little touthettes there with pipette and suction on it, and so that we can clean once, twice, however many times a day that your institution requires while your patients are in the units. GI system, direct correlation, that inflammatory process that can trigger our Crohn's disease patients. Very highly indication of a connection there with Crohn's disease and the GI system. The renal system, chronic kidney disease. So now we're talking about, those vessels that are being destroyed and sending that bacteria into end organs. and that's some of the end organ damage that could occur. Your endocrine system, diabetes, which is a directional process, and I'll go more into that. Again, when we are in an infectious and inflammatory state, our body revs up to say, hey, we need more sugar, we need more glucose in the area, and so our blood sugars tend to go up. And of course, in pregnancy, for the OB nurses out there, prematurity and low birth weight is a direct correlation to mothers who have poor oral health care. Think about it. It's a systemic flow of oral disease and bacteria that flows systemically through us and flows systemically through the baby, which can cause prematurity and low birth weight. Diabetes. I put a little blurb just as a reminder for those who are not in the endocrine area anymore, but the body's inability to maintain glycemic control due to poor or no production of insulin or systemic resistance. Prolonged levels of hyperglycemia can cause negative effects on heart, eyes, kidneys, peripheral nerves, and oral health. So what's this bidirectional thing I talked about? The chicken before the egg, right? Hyperglycemia negatively impacts oral health as evidenced by poor tissue healing, okay? However, oral infections and/or disease negatively impacts glycemic control as evidenced by elevated serum glucose levels. So which one comes first? Again, I don't know who came first, the chicken or the egg. We can debate that all day, but it's definitely a cycle and a two-way street going for diabetes and oral health. So what's the plan for that? The complications, high risk factor for periodontal disease, because there's no healing, or poor healing. That inflammation, the production, of abscesses and things of that nature, bone loss, that vascular complication. Again, those end organs aren't getting the nutrients that they need and dying off. Abscess formation, and of course, poor healing. Cavities, serostoma or dry mouth, candida or thrush, and glottitis, that tongue is thick, red, inflamed, swollen in that mouth. So how can we provide preventive oral health care for our diabetic patients? Twice a day oral health regimen, brushing and flossing. And I can say from my experience, I'm a little rough with my teeth, right? As I think some people are, and they have a lot of devices out there to help us with brushing and flossing. I don't prescribe to anyone, the choice is yours, but it's a soft toothbrush. So the harder you brush or scrub, the more likely you're going to damage the gum line that's holding your teeth in place. So be nice to your teeth. Don't do like me. Some toothbrush have a timer. You want to brush for at least 2 minutes. Some toothbrush, if you brush too hard or press too hard, it stops working. So you have to back off. So there's a little control to it. Frequent oral health checkups, mechanical removal of that biofilm, which is plaque. So we need to get a little scraping done so that bacteria doesn't sit and then stay in the gum line. And then oral antibiotics sometimes is necessary, especially when we talk about the cardiovascular effects, pre and post sometimes procedure. Those patients, especially if you had any work done on the valves, need to have prophylactic oral antibiotics for their oral health care, either an hour before or an hour after, or both, depending on your cardiovascular state. Glycemic control, right? We need to make sure we're checking our blood sugars. We need to make sure we're taking our either insulins or anti-diabetic medications. We need to make sure we're getting our blood work done and checking our A1Cs. It's documented we want at least less than 6 to 7. However, the lower you have it, the better it is for you systemically. Healthy diet, fruits, veggies, make sure you have your proteins, nothing too hard because you can crack the enamel. And then now you're in the emergency room or dental emergency to fix a cracked tooth, you want to make sure it's nothing too sticky. I love caramel and I love Twizzlers, but those things are chewy and soft, and it takes a long time to get it off of your teeth surface once you've eaten them. So when we talk about after each meal or a minimum twice a day, that's the reason why. Refraining from things that have too high of an acid, because you're making the area in the mouth more conductive or conducive to bacterial growth when you lower the pH in the mouth. Abstain from smoking or tobacco use. Okay, vaping is included. And then absolutely 100% an oral health educational program designed specifically for diabetics. My oral health educational program for children was a preventive one. And I do have to state, I did work with our local South Florida Colgate dental van that would come out to the Head Start centers once or twice a year if they could make it, if we could schedule it. I've worked with outside organizations, and I've brought the South Florida Colgate dental van. And what they do is an open screening. They look in the mouth, they make determinations or evaluations on the child's oral health status, and they make recommendations, follow up in a month, immediately 6 months, continue what you're doing. The purpose of the mobile van is to come into communities that might not have readily a pediodontist in the area. And so it's volunteer hygienists, it's volunteer periodontists, and they have an educational staff on that van, a huge van. Not sure if anyone has had the privilege of seeing the Colgate dental van, but I've worked with them for years, again, since about 2005. It is by consent. If it's entity to entity, there is a consent for them to come out, as well as parental consent for each child. And that consent form and a caregiver. So if you're in the schools, the teacher, if you're in a community setting, the parent has to be there, but there has to be some type of guardianship for the child to be there with their consent form. They get an educational teaching in the van, and then they see the hygienist and or the pediodontist right there in the van. So it's a wonderful thing. There are lots of resources out there for everyone, but definitely an oral health educational program. I call it the OHEP, for not only children or adults, but definitely specific to diabetics. And so the resources are there for everyone. Nurses, please remember, at every level of your nursing career, oral health is our responsibility. It is the gateway to the body. A healthy mouth contributes to a healthy body. And so with that, I thank everyone for being here. I thank you for attending this webinar and workshop. And are there any questions for me?
Thank you so much for this wonderful information. And I know you have several slides of references, which is perfect. So just to reiterate, this will be on the Sigma repository. So if you are interested in looking at those references in detail, the recording will be available on the Sigma repository within a few business days of recording. So you will be able to look at those references in depth along with the other slides. There's been a ton of comments in the chat about how great this information was and how applicable it is, and how do we make oral care affordable and available for everyone. With that being said, I do have one question related to that. The out-of-pocket expense for dental care, even when insured, is unaffordable for most individuals. With good dental care, there is correlation with improved oral or overall health. Why isn't insurance coverage better when cost continues to rise? I think that's a question that we all want an answer to, but do you have any insight, Dr. Miller?
You know what? I always tell my patients and my families, I really don't do monies and I don't handle the checkbooks, but it is an unfortunate situation that I consider I have good healthcare. I'm a fully employed faculty member, and I still have an out-of-pocket expense despite all of the things they list that they cover. I'm not quite sure why. Why isn't oral health on the top of the list like cancers or diabetes or cardiovascular issues? I wish I had that 100% answer, and I do not. This should be a political platform, because we spend so much money as adults, when I've been talking about children, as adults, repairing and restoring, and adults are getting implants and veneers and things of that nature, because that's the forefront of our face, that's our appearance. And I wish I had an answer, ladies and gentlemen, but I don't. I think the nurses that are on this call that are very politically driven and motivated and have a position or stance in your state or region or country should advocate for oral health, and tell the politicians how important it is, and connect with organizations like Colgate, for instance, and other local healthcare institutions, to make sure that oral health is on the list, because I think at this point it's not. I think we're at the bottom of the list when it comes to that, and we should be at the top. So I think our political nurses need to help us out a little bit, because we certainly can. We are the movers and shakers of healthcare. We are the front line. We see it, we live it, we breathe it every day, and I think we need a stronger voice.
Yes, I agree. And this is, not to get political, because as many of you know, if you're familiar with Sigma, Sigma is politically neutral, but there is a place for nurses to have that advocacy in policy related to being advocates for our patients and for ourselves. Because as I see in the chat, and, even us with healthcare and with insurance, we do still have that out of pocket, and at times that is just not affordable. Another question we have is, I think you could probably talk about this all day, but how could we get more nurses interested in learning about this topic?
So at my institution, we are developing. I work. I have a research team that I work with, and we're developing programs to talk about it in our generic program as well as in our nurse practitioner program. It's unfortunately that if you don't know, you don't know what you don't know about what you don't know, right? And so if we introduce it early on in the nursing career at the BSN level, and then reinforce it as we get to the nurse practitioner levels, that's the way that we are developing and creating a model at our nursing institution. It has to be pushed in. If you're a lover of oral health, develop a program in your institution, on your floor, in your units, so that more people will see it. It'll be on the forefront. We have to keep putting it out on the forefront. It's almost like, bad news, right? That circulates more than good news, right? So we have to make it, I unfortunately lost a couple colleagues, and it was senseless, infectious processes that enter through the oral cavity. And so if we don't talk about the bad or the ramifications, we won't get the attention and then be able to talk about the good. That this is preventable. I don't even know what better word to say than preventable. But go in your communities. I go to outreach. I work in the church. I am involved in service organizations, sororities. Wherever I can pitch it, that's where I pitch it. And so I will walk around with my oral health kit, so that everyone, it's on the forefront. But I think as nurses, starting at the BSN, well, for me, starting at the BSN level, we incorporate a program into our curriculum. But even as a CNA or nursing assistant or the LPN programs, it needs to start there.
Wonderful. And the next question, I think you kind of answered in this last one, but any specific ideas on how retired nurses could assist in oral health promotion? And I think, integrating it into conversations is a great way, but do you have any other tips?
So for the retired nurse, God bless you for all your service. Um, Definitely keeping engaged. And again, if oral health is a topic of interest for you, connecting with the entities that are for and pro oral health. Local organizations, your state organizations. For me, Florida Nursing Association, I have presented to them, and you know given information and resources to let them know this is what I have done as far as oral healthcare in the region or in the local area, so that they know what's going on. So for the retired, I think the state organization might be a good step. If you're politically charged, definitely go sit at your representative's office or your mayor's office or state representative's office. And talk about why oral health is very important. They listen to nurses. We just don't talk enough.
I agree. I definitely agree with that. And then what about, and I know that your focus is more on pediatric, but can you share some of the oral health programs that are available for adults that have the diagnosis of diabetes?
So I use a lot of the resources from the CDC. And it can give you certainly links, and I've put some of those on my references. But for diabetics, especially connecting with an endocrinologist or office or facility, so that they can incorporate. Again, it's really us teaching them how to care for their patients, and we're nurses, we do a better job at it. And so we need to connect with, and again, I said the CDC, we need to connect with organizations, the American Diabetes Association, AARP. I know the representative for this region, and oral health is on the list as well. So it's almost a word of mouth, networking, who knows who, so that you can put the plug in. But definitely state organizations, AARP, American Dental, American Diabetic Association, those associations, need to know the correlation between the two. And I'm sure they do, but we need to put it at the forefront. Advertising, now we're talking about finances. If we can advertise, there are a lot of commercials on which product to buy. I don't, prescribe to any particular, as long as it has fluoride. I'm a believer of fluoride because the percentage of caries have definitely dropped to the minimum since the inception of fluoride in waters and toothpaste. But definitely a fluoride. If you're rinsing with any, mouthwash, there are a dozen flavors and strengths and what have you, but just to make sure that, you're rinsing so that you can flush between the teeth. Flossing, absolutely, so that bacteria doesn't sit between the teeth. But the advertising, again, if you have the funds for that, is wonderful. Colgate does a great job of it. Crest, all of the companies do a great job at promoting the products, but we need that background of what the education is, why we're doing what we're doing.
Yes, thank you so much for all of that. And just to let the participants know, Sigma does have a oral health equity leader pediatric care course. And this course is designed to walk you through what childhood caries look like, addressing the prevalence, etiology, risk factors, and consequences of oral disease in children. So if you would like to learn more about that, you can go to sigmanursing.org and look for the Oral Health Equity Leader pediatric care, you will receive a virtual badge and a kit, as that course is also sponsored by Colgate-Palmolive, like this webinar was. Dr. Miller, do you have any other parting words before we close up today?
Yes, thank you all so much for attending. It's a delight to share my passion with you all. Stand up for oral health. The mouth is the gateway to our body, general health and overall health, wellness. And fight for little kids. They need to know they'll turn into healthy adults that love brushing and flossing. Thank you, everyone.
I love that. So thank you so much to you, Dr. Miller, today for presenting this great information. Sigma is grateful that you took the time to share with this audience, and we definitely look forward to hearing more from you in the future.
Absolutely, my pleasure.
Of course. We hope that you enjoyed this webinar. As a reminder, 1 week from today, we will email you a link to the evaluation for you to obtain your continuing professional development certificate. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. Thank you so much, everyone, and have a wonderful day.
Bye-bye.